Good evening. Today we have the Uro-Oncology section webinar, and it is about localized prostate cancer, and it's a favorite topic of everyone because there are a lot of controversies regarding the method of treatment. And then we have an excellent panel today. I will be followed by Dr. Lakshman Prabhu and Dr. Amit Ghosh, who is chairman, Uro-Oncology section of USI. And then we have Dr. Srivatsa and from Bangalore, and Dr. Anand Krishnan, who is a robotic surgeon from Chennai. And we have two sessions, session number 1 on diagnosis and session number 2 on case discussion. So I hope that we are going to learn some new tricks of the trade, and then I will request Dr. Lakshman Prabhu to have introduction. Thank you.
No, thank you very much, sir. I must only say here that of all the sections, Uro-Oncology section has been doing exceedingly well, and they have stuck to their promise of education. And we have already seen fantastic webinars till now. I think last month also we had a couple, and this month we are seeing one more. And I will only say that there are so many experts. It's an opportunity for all of us, particularly the officers of USI, learn by default that whether they like it or not, they are there in most of these sessions, and good things get rubbed onto us. Like if you always, I say that if you rub yourself against sandal, you will take away a little bit of fragrance. So I would request the section to take the webinar forwards, and we have very little talking to do. All the best, and I'll be there listening to it, and I hope that all of us logged in will have plenty of learning to do today. And thanks once again, and over to Dr. Amit Ghosh for the conduct of this webinar.
Good evening, everybody. Good evening yet again to the Uro-Onco webinar. I just wanted to put in mind a little bit before the webinar. Please don't mistake that the target of Uro-Oncology section is webinars only, because webinars can be done by anybody and everybody. We are trying to involve as many of our 4,000 members as possible so that we can percolate the knowledge to everybody as they want to receive it. One of the challenging episodes that we have planned, actually there are two, but I'll first tell you about the one because it's nearly full house now. And that is, first of all, thanks to all the faculty that each and every senior member is actually very eager to participate, which is a very good sign for Uro-Oncology. The new members, or rather the younger members, I would urge them to actually help us construct a very good annual program which is happening in Rishikesh. AIMS Rishikesh has taken the charge. Ankur Mittal is the organizing secretary, and we are having an extremely robust program over there for 1.5 to 2 days with live operating. What we need the help from you is, it will actually enthuse us that you actually show interest and actually register for it. So my appeal today is, and from now on, every webinar will keep reminding you, please take an active interest in becoming members, and please take an active interest in making the annual program a big success. This is not just for the heck of it. We are actually trying to build an international platform. We have already got an extremely lucrative offer that all members of Uro-Oncology section will be given a free access to international journal and knowledge bases like the BJUI. So we are working our level best, and we would welcome any suggestions from you for improvement. But only one appeal, please participate and spare some time for all the webinars, and particularly the annual function at Rishikesh. Now over to the speakers for today. Anand, can you do the honors of starting it?
So good evening, one and all. So today being the day for localized prostate cancer, we have a star cast of speakers today for you. And also great panelists coming around. I'll introduce them as we go along in the session. Now, the first speaker, on behalf of my co-moderator, first I'd like to introduce him. He's Dr. Srivatsa. He's one of the top uro-oncologists from Bangalore. And then the first speaker today is Dr. Anila Kurian. She's a pathologist, a uropathologist. The mark of a good pathologist is when they focus themselves to a particular field. And when, in Chennai those days, when people were afraid of branding themselves as a focused uropathologist, she started a lab called Renopath, and she's one of the foremost uropathologists of the country. She's become the de facto reference center for all uropathology down here in Chennai. So I have great pleasure in introducing to you Dr. Anila Kurian, and she's going to talk about the usefulness of immunohistochemistry. And expert comments in this session is going to be by Professor of Urology from CMC Vellore, Dr. Santosh Kumar, who I'm sure none of us need to be introduced to. He's one of the great teachers of our era. So without further ado, I'm going to ask Dr. Anila to start. Madam, the screen is all yours.
Thank you so much, Dr. Ananthakrishnan, and thank you so much for your very kind words of introduction. And I sincerely thank the USI for inviting me for this talk. So I've been given to talk about the diagnostic utility of immunohistochemical markers in prostate cancer. Now, what are the indications? When do we do immunohistochemical markers, or why do we do immunohistochemical markers on a prostate needle biopsy? It can be divided into three main indications. The first being, yes, to define or differentiate whether it's a benign or a malignant gland under these following conditions. We'll go to the details of them a little later. The second main heading under which we want to do immunohistochemical markers is to identify whether the tumor in the prostate is actually a primary prostate tumor, or is it a tumor that is infiltrating from another nearby organ or a distant organ. So that's the second indication. And finally, the third indication is when you have a distant metastasis, you want to know whether the origin of that metastasis was from the prostate. So these are the three main indications for doing immunohistochemical markers on a prostate needle biopsy. Right. Now, what are the markers that we do? So it can be classified under three big headings. One is the basal cell markers. As you know, in a tumor, a malignant, the definition of a malignant gland in the prostate is they should lack basal cells. So you need to highlight the absence of basal cells. So we do markers for basal cells and show, yes, there are no basal cells in those glands. So those are the basal cell markers. You could do one of them. Now the most popular one is a P63, but any of these are good enough. Then there's something called the tumor specific marker. These are markers that will stain only a malignant gland, or sorry, a malignant cell, and will not stain a benign cell. So this will only say, yes, this cell is a malignant cell, or the absence of it will suggest that it's a benign cell. So that is a tumor specific marker. And finally, you have markers that are prostate specific markers, meaning they may not tell you whether it's a benign or a malignant gland, but those markers will tell you, yes, these tumor cells are originating from the prostate. So we have a set of them. We have many more to this list, but I've just enlisted the common ones for you because these are the ones that are used day to day in most of the laboratories. All right. So how do we, on light microscopy, how do we make a diagnosis of a malignant gland on the biopsy, or how do we make a diagnosis of adenocarcinoma of the prostate on a needle biopsy? So the pathologist looks under the LOPA, and then we have certain architectural features, right? There are features like how are the glands placed? Are they small and rounded and crowded? Are they infiltrating into the surrounding tissue? So those are the architectural features of malignancy. Along with them, we always have to look for the cytological features, that is individual cell. That is, you look how is the cell enlarged? Is the nucleus large? Is there a prominent nucleolus? Are there basal cells in the epithelium? So these architectural patterns and cytological patterns, we combine them, and then we decide based on these whether this gland is a benign gland or a malignant gland. So that is how a pathologist on a day-to-day basis diagnoses a malignancy. Now it's easy when all the features like the gland, the tumor is showing the characteristic benign and malignant features. But as you know, many a time, the tumors don't follow the exact protocol. So you may not see all the architectural features. You may not see all the cytological features, and that's when we resort to immunohistochemistry. So the most commonly used markers are the basal cell markers. As I told you, the diagnostic hallmark of malignancy is absence of basal cells. So this is a picture here of a tumor I had recently. P63, we've stained it. That's a basal cell marker. And the top left, you have a cluster of glands which are benign. They are benign because they have a beautiful basal cell surrounding it. And you should remember, in immunohistochemistry, whatever is positive is a dark brown color. If there's no brown color, it's negative. So wherever you see the brown dots, these are all the basal cells. So they've taken up the stain. Now, what about all the glands at the remaining part of the picture? You can see glands, but none of them have any basal cells. So this is most likely malignant glands, because by definition, malignant glands lack basal cells. So this is being used when you have small cluster, like an atypical small SNR proliferation. You have benign glands and then probably 2-3 glands here. You can see a prominent nucleus. You're not sure whether it's benign or malignant. Then we do a immunohistochemistry for basal cells. All the benign glands have it, but this cluster, there's complete absence of basal cells, so it's likely a malignant gland. So this is especially used when we have adenosis or atrophic gland. Now, adenosis is a benign proliferation, crowded, tightly placed or clustered glands, which can resemble a Gleason pattern 3, but they're different from Gleason pattern because the glands have basal cells. So by definition, it's a benign gland. So to differentiate Gleason pattern 3 from adenosis, do a basal cell marker. If you have basal cells, it's likely a benign and not a carcinoma. Same way for atrophic glands. Atrophic glands can be very small. They may look as though there is only a single layer. You're really not able to identify the 2 layers very clearly. You can see that only one single layer is there. But when you do an immunohistochemical markers here and there, you have basal cells. So these are just atrophic glands and not malignant glands. So that's one way when we use basal cell markers. Also for atypical small SNR proliferation, multiple cores, a 30 core or 40 core needle biopsy, 1 core and 1 small focus of 5 to 6 small glands. You need to have a more reassurance to call it malignant. So do a basal cell marker. Basal cells are present in the benign glands, completely absent in the malignant glands, and then this helps us to make the diagnosis. So you may, this may sound very easy, like, the pathologist just has to do a basal cell marker and the diagnosis is there. But it's not practically always, because there are certain pitfalls in the sense, even a benign gland may not have basal cells. And just because you're not seeing basal cell, it is not an absolute criteria for malignancy. It's very suggestive of, but that alone cannot be taken as a only criteria for malignancy. So now we have to do markers of malignancy to prove that those glands are malignant. So now what are the markers of malignancy? The most commonly one that is used in prostate is AMCAR, alpha-methyl-CoA racemase, which is not seen in benign prostate tissue. Only the malignant glands take up the stain. But you need to remember, they are not specific for prostate. You can see they will stain positive for colon cancer, lung, lymphoma, melanoma. So for a variety of malignant tumors, they are positive. They will only tell you whether the epithelium is a benign epithelium or a malignant epithelium. So here is a cluster of glands. You're not sure whether it's benign or malignant. Do AMCAR, and all the malignant glands have taken up the brown stain. Post-radiation, it's especially useful because the glands become really atrophic, and then you find it really difficult to identify them on light microscopy, whereas AMCAR will highlight it up. So that's one of the main uses of a malignancy specific marker. But then again, this too has pitfalls. And what is that? Even a high-grade pin will stain positive. Some foci of adenosis may stain positive, and occasionally even benign glands may stain positive. So again, you cannot solely rely on this for identifying malignancy. Now, the other way around, there are certain tumors, even though it's malignant, may have a false negative picture. So they can be false positive and false negative in this. So you cannot completely rely just on this marker. So to overcome the shortcomings of the basal cell marker and AMCAR, now we have something called a cocktail markers, or a double or a triple staining that we do, where we do basal cell markers and malignancy associated markers to bring out more features to help us very accurately diagnose whether they are benign or malignant. So I'll show you a picture. This will make it easier for you to understand. So here they've used a cocktail of basal cell markers and a malignancy marker. So the basal cell markers, these are the benign glands, right? The large glands with, tufted epithelium. So benign glands all have the basal cell marker. And this is the malignant gland, what is taken up in red. None of the malignant glands have basal cell markers. Instead, they have the AMCAR, which is a marker for malignancy. Whereas AMCAR, the marker for malignancy, is absent on the benign glands. So when you see glands which don't have basal cells and only AMCAR, they are likely to be malignant, and the other way for a benign gland. But PIN is something where, as by definition of PIN, is architecturally benign. So they have basal cells, but cytologically malignant. So the epithelium is malignant. So PIN is a condition where the gland will have both the basal cells and the malignancy markers. Now, finally, coming to what are the prostate specific markers, and this is the most widely used marker, is a prostate specific antigen. But you need to know, though the name calls it prostate specific, it is not really very specific for prostate, because you could see it in malignancies of the breast cancer as well as salivary gland tumors, especially pleomorphic adenoma, are strongly PAS positive. But it will tell you whether it's a tumor arising from the prostate. So this is a true cut biopsy of the lymph node to know what the primary site is. Do a PSA, it's positive. This is a prostatic tumor which is metastasizing to the lymph node. And now the newer marker is NKX3.1, which stains the epithelium very nicely, the benign epithelium as well as the malignant gland. So now this is more preferred than PSA. One of the drawbacks of PSA is if it's a high-grade tumor or a poorly differentiated, like Gleason pattern 5, it may falsely be negative. Just like, the serum PSA is also not high in those poorly differentiated tumor. Same way, the tumor cells also may be falsely negative. Whereas NKX3.1, even if it's a poorly differentiated, tends to still be positive. So this is a more preferred one now that we are using for identifying prostate in origin. And finally, how do you differentiate whether it's primary prostate or primary bladder? You do a set of markers which are specific for prostate, and you do markers that are specific for bladder, and then you see which is positive. Based on that, we decide whether it's a primary prostate or a primary bladder. Same way for the colorectum, markers for colorectum, markers for prostate, we have to do both, and then we assess what is positive and then make the diagnosis. So all this while I was talking about the role of IHC in diagnosis. Now recently there have been some studies about finding out whether these markers can be useful for prognosis and for risk stratification. As of now, these are only research papers. There are stray papers in publication. None of them have been actually validated for routine clinical uses as of now, but I'm sure that in a matter of time, we may be using immunohistochemical markers for the prognosis also. There are a number of markers that have been used. I'm not going into the details for that for lack of time. Quickly, one case here, one slide. This is a patient of a young, 67-year-old with bladder outlet obstruction. It's a pyrite 5 lesion with prostate infiltrating the bladder. Light microscopy, a poorly differentiated Gleason pattern 5 appears to be Gleason pattern 5. However, prostate marker is completely negative. So this is not a primary prostate tumor. This is GATA3, which is a marker for bladder. And this was actually a primary bladder tumor that is infiltrating the prostate. 70-year-old patient, recurrent UTI, PSA 9. It's a pyrite 3 lesion and a 36 core, 1 core, small focus of these small glands, closely packed glands. I cannot see the basal cells here. Is it adenosis? Is it malignancy? Is it atrophic glands? So I do immunohistochemistry P63. P63 has come positive very nicely on all the cells. So this is most likely a benign gland. It's not a malignant cluster. An 81-year-old patient with inability to pass stool and urine for the past 2 days. PSA was 4. Rectal examination, mucosa was fixed. Pyrites lesion 5 involving left lobe, left seminal vesicle, and anterior wall of rectum. Just sheets of malignant cells in the bladder, in the prostate needle biopsy. I think this was a 6-core biopsy. All of them, I couldn't even make out a primary, the native prostate tissue. It was just tumor everywhere. did an NKX 3.1 positive, CK20, which should be positive in a rectal tumor, was completely negative. So this is a primary prostate tumor. And finally, other patient with a PSA 2.2 hard nodular pyroids 5 lesion, just sheets of blue cells and no glandular differentiation, no cribriform pattern. I didn't put the picture. It was an NKX 3.1, yes. But here, this is a marker of neuroendocrine. INSM1 is the new marker. The older markers were chromogranin and synaptophysin. But now this is like the best marker for neuroendocrine differentiation. So this was a tumor which was actually a neuroendocrine tumor of the prostate, and immunohistochemistry helped us establish that diagnosis. So to conclude, what is the impact of immunohistochemistry? As far as pathologists, it's helped us in diagnosis. But for the urologist, what is the impact of immunohistochemical staining? One is you can avoid a delay in the diagnosis. Second, this I think is even more important, you can avoid unnecessary repeat biopsy. And finally, if the prognostic markers and risk stratification actually comes into clinical use, it would be a good means in which way you can plan the treatment for your patients. So I'd like to end with that. Thank you so much.
Thank you very much, Dr. Anila. It was a very, very good talk. I'm going to invite Dr. Santosh Kumar, Professor of Urology, CMC, to give some expert comments on this lecture.
Good evening. I hope you can hear me.
Yes, sir.
Yeah. So thank you, Dr. Anila, making a difficult subject very easy. It's always a pleasure listening to you. And thank you, Anand, Dr. Amit, and Ravi to have me. So the first thing is, I think, as a resident, when we were training, the first thing was, oh, you have done lymph node biopsy in the subclavian region, or you have done a bone biopsy, neurosurgeon, do a PSA staining. We don't need to repeat the prostate biopsy. That was all the role of immunohistochemistry was there 20 years back when we used to do. So that we thought that we were very right. I feel bad for pathologists that life was very colorful, you know, with the hues of colors that they saw before, and now the whole life is converted into this rusty red immunohistochemicals, this thing, and it has made so much difference to the way we look at cancers. She has elaborated very clearly in early prostate cancer how to diagnose. I think the time was less and she could not delve into the real prognostic markers, which is probably where the future is. Ki67, P53, ERG, P10, MYC, all these will probably guide us in future. You know, as of now, we have only these clinical nomograms, and I'm sure the IHC with further research will come out in a way to tell us amongst these patients who probably with active surveillance who are likely to progress. And that way, probably they would help us a lot. I am sure she had a lot to speak on that because of restriction of time. Dr. Anila hasn't been able to touch to us. We'll be listening more about it in future. Thank you, Anila, again for a wonderful talk. I won't take more time. I think we have 15 minutes left for this.
Thank you, Dr. Santosh. Dr. Anila and Santosh, may I request you to stay back for the rest of the program? We've probably got questions for you in the case discussion. Now, the next person who's going to talk to us is a surgeon that I admire.
Can I interrupt? Because Professor Narmada Gupta has asked a very relevant question. Who asks for the IHC, urologist or pathologist? Maybe can somebody answer that, please?
It has to be the pathologist, without a doubt.
Okay. Narmada ji, are you happy? Very good. Anyway, let's carry on.
So the next talk is by Dr. Kishore, uro-oncologist from Aster Medicity, Kochi. He's one of the surgeons I admire, adventurous, very quiet, but he makes his work do the talking. And the expert comments for this session is by Dr. Yuvraj, again, a phenomenally good surgeon from Mumbai, uro-oncologist. So he's going to talk about, Dr. Kishore is going to talk about Retzius-sparing, when not to do Retzius-sparing, and Dr. Yuvraj is going to bring in his expertise for the same. Go ahead, Dr. Kishore.
Thank you, Dr. Anand. I have a small problem with my video, so I might have to switch the slides because my PowerPoint is getting stuck. So first of all, I express my gratitude to Anant and USI Uro-Oncology session for having me here. So I would like to share my experience of the last few years, 7-8 years, where I've been doing the Retzius-sparing prostatectomy. So as you know, the Retzius-sparing prostatectomy was initially proposed by Boschiardi in 2012. And since then, it has caught the imagination of the surgeons, especially the urologists all around the world. So there were certain pockets, Dr. Ravel, Dr. Kundra, they were all experts, and the rest of the surgeons are picking up across the world. So I started my journey in 2016 when I was still in the early days of the classical prostatectomy also. So the major advantage I saw with the Retzius-sparing is that it's very improved continence. Because from the day of the catheter removal, you get very robust continence. And I feel it is slightly faster than conventional procedure, even though it's debatable. And in my experience, I have a better preservation of the potency along with that. What are the cons? So since we are going close to the prostate, I mean, we don't spare any fat or the prostate. So I think we have a definitely higher positive margin rate, but this has been contradicted in many studies, because many of the studies have not shown positive margin. But in my experience, I think I have had positive margin rates. And the learning curve is steep. It's really frustrating, especially for the initial cases. But once you are in that flow, you will enjoy the procedure. And it is not as clean procedure, especially in the beginning stages compared to the conventional RARP, because you get into the dorsal veins and anatomy may not be familiar. And it needs a skilled assistant. We have to have a very skilled assistant for assisting the Retzius-sparing prostatectomy. So as you know, the 4 stages of the competency. So you have to choose your cases when you reach these 4 levels of competency. And I have divided the complexity of these prostates into 4 levels, similar to this. So if you see the data, my institution data, in the first 100, last 500 prostates, in the first 100 cases, there were only 25 Retzius-sparing. Then it became 32. Then slowly surpassed the classical by 77. Now, most of the cases we do 89-90% of the patients we do Retzius-sparing. So there are only very few contraindications for Retzius-sparing. So this is the curve, the crossover curve. The Retzius-sparing has taken off, and the conventional, the classical surgery has gone down in our institution. So what would be the ideal case when you embark on Retzius-sparing? Ideally, you take the patients, the low PSA, thin patients with wide pelvis, and it should be early case. And the best plane for Retzius-sparing, the natural plane, is intrafacial nerve sparing. So I just want to show a video. I might stumble a little bit here. Let me share it. Yes.
Yes, we can see the screen.
Perfect. So this is a very early case, very rather easy case from the Retzius point of view, wide pelvis. So you make a incision in the posterior peritoneum. As the pelvis gets narrow, you can make a wider incision. Effectively, you have to open up the pelvis. That is the basic tenet behind that. So you get a good space. In this case, it's a wide pelvis, so I don't have to open the peritoneum as much. Here, basically, I'm going intrafacial nerve sparing. So you go very close to the prostate. It's like peeling the onion. So we go intrafacial, very close to the prostate. So, and these are the pedicles. Either you can clip, or now I just spot coagulate. I just cut it and spot coagulate, which is also quite effective because the clips can sometimes slip off. And you don't get into any of the big veins. When you're going into the intrafacial planes, you're not going into any of the big veins. So this is the division of the pedicle. And now this is the anterior dissection. So once you take the pedicle of the prostate, you are literally peeling the detrusor apron and the bundle of the prostate. So we are going very close to the prostate. The advantage is that you preserve all the periprostatic tissue. And you can see the urethra here. I'm keeping the bipolar across the urethra and then dividing the urethra. So you do the dissection on both the sides and then eventually isolate the urethra in the midline. And then that will give your way to the apex. So you can see there is only a small portion of the detrusor apron attached, and the prostate surface is very clearly seen on the anterior aspect. So this will give our access to the apex. You don't see any dorsal vein in this procedure because we're going intrafacial. And if you go really wide, you'll get into the dorsal vein. That is the extrafacial. So here I am dissecting the urethra, the apex. So you don't encounter any of those large veins. And once you can get the maximum length of the urethra, then we proceed with the suturing. So I suture with on the one side, I suture start at like 2 o'clock and then start on the other side. And then these two sutures will meet at the 6 o'clock position. The suturing can be tricky initially, and you have to use a 30 up in most instances, or sometimes you can get away with a 0. But even I used to take 25-30 minutes for the suturing, but now I'm as fast as the classical. I hardly take 8 to 10 minutes. So just the learning curve. So once the suturing is complete, we close the peritoneum in the non-nerve sparing. So coming back to the slide. So this is an ideal case. Right? So when you start your like first 10, 15 cases, you choose this. So what would be the second level case? So you can take mild obese patients like BMI between 25 and 30. Patients who have narrow pelvis can be taken, although there is a struggle involved. Patients with small median lobe and mid-sized prostates, not like 150, maybe you can take 70, 80 grams. So this would be the ideal for a level 2. So once we are beyond the learning curve of 15, 20 cases, you can venture into this top sort of anatomies. And then comes the level 3, I would say, we can take a larger median lobes and prostates of larger size, which does not have very aggressive cancers. You can take that. And then comes the level 4, where you can take complex cases like post-URP, post-HOLEP, and locally advanced cases like where they have posterior infiltration and super obese patients. These are quite difficult. Again, it can be frustrating, the obese patients, but it is doable. So I just show some examples of that. One second. So this is the post-HOLEP patient. So you can see the picture, right? Anand?
Picture is seen. Yes, picture is seen. Go ahead, please.
So this is the post-HOLEP. So you don't have the bladder neck in that because especially the laser prostate surgeons, they do a wide resection. So you don't have the bladder neck. So anatomy can be a little bit confusing. You can get into the ureteric orifices. So initial cases, you can put bilateral DG stents or a ureteric catheter, but it is quite possible. The only, con is that you get quite a big bladder neck, which happens even in the conventional, but the continence rate is excellent compared to the conventional radical prostatectomy. The continence with the HOLEP is quite good. So. Then this is the one with the large median lobe. So the median lobes, benign kind of large median lobe without bladder neck infiltration, it's quite possible to take for Retzius-sparing, and it's easier than probably the classical. So we again peel away the detrusor muscles and the bladder from the prostate. So this is a really huge median lobe. So again, the urethra can be isolated. Even in these cases, urethra can be isolated and you can get a fairly good bladder neck. And here is still bigger. It's a 180 median lobe. Here you can see the bladder is snugging the median lobe. So I make move away the bladder and you can get a fairly good bladder neck. So the bladder neck size is slightly better than what we get in the conventional radical prostatectomy. And continence rate is better. So here also we don't go wide. We just and this is another one here. This is a little bit of this probably comes in the final phase. This is a patient which have a bladder neck infiltration. So here you one side is infiltrated. So you see, I've really gone wide onto the bladder, and you can see on the other side, I'm going close to the prostate, and this is infiltration. So you can see the bladder on the this aspect, on the posterior aspect, and it is very close to the ureteric orifice. So here the retrosal apron is not preserved. You're going really wide. You're cutting into the endopelvic fascia. But the more wide you go, the benefit of Retzius-sparing is gone. So this will almost behave like a conventional radical prostatectomy. So the benefit of continence may not be there. But here I'm going really wide. You can see the periprostatic fat, endopelvic, everything is really wide. And once you take out the specimen, you can see the fat of the specimen. And once it is taken out, I will cannulate the ureteric orifice because my anastomosis is very close to the ureteric pipe. So then you do the similar tennis racketing. You close the bladder vertically down the posterior and then do the anastomosis. So this probably can be attempted only once you're done, maybe 100, 200 cases. Otherwise, you might injure the ureter. You do have to reimplant. So unknowingly, you can injure. You have to know the roadmap before you do that. Can you hear me?
Yeah, yes, Dr. Kishore, go ahead.
Just, yeah, okay, sorry. So just go back to the slides. So there are certain indications where Retzius-sparing is really superior compared to a conventional radical prostatectomy. That is, one is previous hernia repair, and then you can have post-ureteric reimplant and post-renal transplant cases. So I will just show the video of that. You can see the video, right? Anant, you can see the video?
Yes, Kishore.
So this is, nowadays hernia surgeons, they keep wide meshes in the periperitoneal space. So it's a challenge going into that space when you do the classical RARP. This is a case where a big mesh is kept, and you can see the adhesions onto the sigmoid colon. So once you release all the adhesions, you can have a clear path doing a Retzius-sparing. So you don't really have to excise the mesh, or you don't have to go into the mesh creating. And this is one post-renal transplant and liver transplant. The graft is placed on the left side. So you don't have to meddle with the ureter. You just go posteriorly, and even the lymph node dissection is quite possible. So these are certain cases where these are the untold advantages of the Retzius-sparing. So I would say my contraindications for my procedure is right now is bladder neck infiltration. Apart from that, but you have to probably weigh your experience before embarking on locally advanced cases. But you can have the same results even in locally advanced cases, especially in posterior infiltration. So I would say summarize, you tailor according to the surgeon's experience. The disease status, quite important. If you're not comfortable, don't take advanced cases initially. Prostate configuration, larger prostate, median lobes, later in the learning curve. Obese patients, again, later in the learning curve. Currently, I would say only contraindication, absolute or relative, is the bladder neck infiltration, which probably does not confer any advantage doing a Retzius-sparing. Thank you.
Thank you very much, Dr. Kishore. That was a very good lecture. and talk. And I'm going to invite Dr. Yuvraj, one of our senior uro-oncologists from Mumbai. Dr. Yuvraj, your comments on when to and when not to do Retzius-sparing. Dr. Yuvraj?
Yeah, I think my voice has been muted. Can you hear me now?
Yes, yes, we can hear you. Go ahead, please.
Yeah, okay. So I think video, they have not started the video. It's fine. I think it was a wonderful presentation by Kishore. I think this Retzius-sparing surgery, although it was very popular in European countries and in US, it is not that popular. I can say that. And I think there are pros and cons of each one of them, whether we do Retzius-sparing or a standard approach. I think Retzius-sparing surgery is, as Dr. Kishore told, that it's a procedure to be learned very carefully, selecting patients in a graded manner. So that is how we have to do that. But what I feel personally is that whatever we do anteriorly, even a Retzius-sparing can do it, and vice versa. So I think it is just a surgeon's choice. And the continence, I would agree with him that, it's a better continence as far as the early continence goes. Now with the continence is also, a lot of improvements in anterior approach, especially, the hood technique, which is really completely saving. It's what I can call it as a reverse Retzius-sparing procedure. So where we, save everything, including nerves and the periprostatic tissue. And we have a comfort of anatomy which we know the anatomy, which is an anterior approach. So according to me, I think both procedures are okay. As far as continence goes, at the end of 6 months, I don't think it makes any difference whether we do it in a Retzius-sparing way or this thing. It is just a one comfort. And I think all the prostates can be removed by anteriorly. And only one question I have, Kishore, if I want to ask, is that in a case of patient who has a post-APR, so is he comfortable doing a Retzius-sparing? That's the only one question I have. Otherwise, it's a good technique, especially when the bladder is adherent to the anterior abdominal wall. Thank you so much.
I have not done Yuvraj so far a post APR. APR may not be challenging because rectum is not there, but post LAR might be more challenging. So LAR. So one case I've lined up, so I will probably inform you. It's coming next week, but otherwise I have not done so far. I think that still could be a challenging one. Yeah.
Fine.
So
thank you.
We've got a very good question from Dr. Santosh. His question is regarding positive margins. In T3 disease, the margin rate is going to be much higher in Retzius. What are your thoughts on that, Dr. Kishore?
No, see, I think the secret behind margin positivity, you keep a lot of fat on the prostate, because you keep a lot of fat on the prostate, you're going to get margin negative. So my problem is that, say, when I do really intrafacial nerve sparing, you are very close to the prostate. So then even in early cases, you will get positive margins. So my problem actually is more with the early cases where you don't expect positive margins in a normal instance. But with PT3, you can go really wide. You can go really wide, preserve fat on the prostate, then you will not get positive margins. So it's just the more wider you go, less chances of positive margins, and wider you go, the less chance of benefit of reduced benefits of the Retzius-sparing. So margin positivity is my main problem is with early cases when you go really intrafacial and go close to the prostate. So, but advanced, I think with elderly patients whom we are just going to take out the nerves, I mean, the margin positivity is not been a big issue for me.
Okay, thank you, Dr. Kishore. Now, another follow-up to your point regarding renal transplants and robotic prostates. Whenever renal transplants been done, we only try and drop the side of the bladder that doesn't have the kidney on, and then go into the space that we need, the Retzius space, and do it. So even anterior approach is possible with the renal transplantation. But your point is very well taken that if there's a renal transplant, Retzius-sparing might be a good approach to take. So thank you very much. I would ask both Dr. Yuvraj and Dr. Kishore to stay behind for the case discussion. And I'm going to hand it over to a very, very good uro-oncologist, a voice of clarity, Dr. Srivatsa, to take the next session forward. And he's got a star panel with him. And Dr. Srivatsa, you should introduce your panel before we start. Go ahead, Dr. Srivatsa.
Very good evening to all who are there. And thank you, Anand sir, and thank you, Uro-Oncology subsection of USI for this wonderful opportunity. So I have reserved a lot of questions to Dr. Kishore during the case discussion itself. And I have a really top-notch expert panel to discuss today's two cases with me. Dr. Raghunath sir from Bangalore, Dr. Sai Shri Harsha from Hyderabad, Dr. Puneet Aluwalia from Delhi, and Dr. Gagan from Mumbai. Welcome all of you. And sir, with your kind permission, can I start?
Please go ahead, Dr. Srivatsa.
Yeah, thank you. So this is my first case. He's a 61-year-old gentleman, non-smoker with an excellent performance status, who's sexually active. He had no lower urinary tract symptoms or comorbidities. He stays in America, and he visited us because his father was being treated by us for metastatic prostate cancer. So he used the opportunity of his visit and screened himself for the first time, and he returned back to us with a PSA of 5.6. We then had suggested that he repeat a PSA after 6 weeks. It came back as 5.84. When we did a clinical examination, he had a clinically benign feeling grade 1 prostate enlargement. So my question to Harsha. Harsha, do you routinely use antibiotics in patients who come to you with intermediate range PSAs, and what are your rationale to use them?
So that was a really good question, sir. First of all, thank you for including me on your panel. It is a real honor.
Harsha, switch on your video, please. Dr. Harsha, switch on your video, please.
I think there's some problem with the video, sir. Am I audible, sir?
Yeah, you are audible.
Yes.
I think there is some problem with the video. It's not running through.
Okay, go. Please answer.
Yeah. So I think coming to the first question, when we start the antibiotics, so unless there is any clinical indication for starting the antibiotics, as in patient himself complains of some form of dysuria or LUTs which are indicating of any urinary tract infection, or a CUV which is showing pustules, we don't routinely start an antibiotic, sir. Coming to the second half of it about the PSA metrics, yes, in this particular case, where there is a strong family history of father having metastatic prostate cancer, I really like to go with the free PSA and percentage and other form of PSA metrics to help me guide for the further workup.
Okay, so do you routinely use a percent free PSA evaluation in this case, or in cases with grade 1 PSA? If there is a particular case where you don't want to use this free PSA, what would that be?
So if there is no obvious, like in Indian scenario, typically in Indian scenario, the gray zone of PSA, which we call, where it goes from 4 to maybe up to 10 we can call, but 4 to 7 is usual cutoff we keep it. So in those cases, if the patient already had a history of prostatitis or history of recurrent UTI, etc., those cases I won't prefer doing a PSA matrix as they won't give much yield of information.
Okay.
Whereas in a strong family history, yeah, we do PSA matrix.
Dr. Gagan, would you also do anything else other than the percent free PSA, like the PHI test, which is available in India, for instance, or you would just stick to PSA metrics alone?
Dr. Puneet will answer this. Dr. Gagan is not with us, I think.
Okay, Dr. Puneet.
All right, then have your senior panel members. Go ahead, Dr. Raghu, please.
So in my clinical practice, I don't do more than total PSA and free PSA. Though other tests are available, but I have not used those tests.
This next
Sorry, I was
question
just starting my video. So yeah.
Okay. So quickly, Dr. Puneet, would you do a PHI or something else on this, or you just rely on percent free PSA alone?
No, I regularly don't do PHI or 4K score. I do free PSA and a normal PSA, and yeah. So from the blood investigation point of view, I'll do that only.
The next question is to Raghunath sir. Sir, would you want to do an MPMRI before you consider a biopsy in such patients, or would you want to do a biopsy first and then do an MRI only if the biopsy returns positive?
No, in this kind of a patient where they come with a low PSA and clinically even suspicious or even normal gland, I prefer to go with MPMRI before biopsy. That will give me a lot of information about PIRADS, where to take the biopsy if abnormal areas are there, what is the size of the lesion, where exactly is it closer to the neurovascular bundle or in the anterior fibromuscular zone. Accordingly, it will help me to take up a plan for my biopsy. So I would certainly do MPMRI before biopsy in most of my cases. Almost all cases I do MPMRI before biopsy.
Okay, I think that even EAU is quite clear on that, wherever possible, you should be doing an MRI prior to biopsy, which will give us a lot of additional information. Dr. Puneet, do you anytime consider doing a PSMA PET CT scan to diagnose prostate cancer? Is there any particular index case where you want to really use it?
No, I don't do a PSMA PET scan at the time of diagnosis. I do a PSA blood investigations. I do a multiparametric MRI for all my cases before a biopsy now. And after that, even for staging, if you want to know, for staging high risk patients, you can do a PSMA PET scan. Even for a lower risk patient who has a PSA, like in this case of less than 10, and if the biopsy proves to be a low risk disease, even then PSMA PET scan may not be indicated.
Okay. Dr. Raghunath, would you like to add anything to that? Would you want to do a PSMA PET CT in any specific instance before a diagnosis is done?
No, I don't do, unless some patients in Bangalore, techies will come and they'll ask, I don't want to go for any invasive tests. Are there any other investigations which will add to MRI? Only in such cases, but in my practice, maybe I must have done once or twice. And even the some evidence is there that people have done even radical prostatectomy based on MRI and PET scan. But it's in my clinical practice, I don't do that.
Okay.
I guess biopsy will definitely be required before doing.
Dr.
Yes.
Srivatsa, I think Dr. Ravi Mohan can add to PSMA PET and biopsy with the use of PSMA PET. I think PGI Chandigarh is doing transgluteal biopsies with PSMA PET. Dr. Ravi?
Yeah, correct, Dr. Anand. Thank you for that question. I think so. In a scenario where you will do a PSMA PET, where you've done an MRI and MRI was showing some lesion, but you do a biopsy after MRI, and we don't have MR guided biopsy. So we do a trust guided biopsy, and it turns out to be negative, and your PSA is still suspicious zone. Then we do a PSMA PET, and we have a opportunity of doing a transgluteal biopsy guided using a robotic arm in the PSMA console itself. So our diagnostic yield is almost 99% whenever there is a lesion on the PSMA, and we have done even for early cases. So that is a situation, but I don't want the participants to take a message that we should do PSMA in early stage. So sorry for that, but then we do it in a select situation where the suspicion is there and yet our biopsy is negative.
Exactly the point that I wanted to highlight, that probably in patients who have persistently elevated PSAs, some lesions here and there on the MRI, but repeated biopsies coming back negative, there might be a small area of requirement of doing a PSMA PET CT scan, which may or may not help us decide whether we need to biopsy some other area or not. But like Dr. Ravi says, the message should be clear. PSMA PET CT scan till date should not be considered as a part of diagnostic tool. So the next question to you, Dr. Raghunath sir, is again, if you consider doing a biopsy on this patient, what do you think is the best way to do a biopsy in the contemporary era?
The best is obviously the transperineal MR fusion biopsy, but that may not be available at all the centers. So if fusion is not available, the next best is at least transrectal biopsy. Transperineal is definitely better if fusion is not there. If transperineal is also not available, then next is transgeric, the conventional prostate biopsy, both systematic and systematic biopsy and targeted biopsy. And probably cognitive can be utilized at this point of time if those technologies are not available.
just highlighting the data that we have already discussed, that we need to do an MP-MRI. It will help us decide whether we are going to biopsy patients or not based on elevated PSA alone. This is what I found in the recent EAU 2023 guidelines, where they are now trying to factor in the PSA metrics as well into the MP-MRI. And then they call it as a risk-adapted matrix table for biopsy decision management. So if the pyrites is low, but the PSA matrix is relatively on the higher side, depending on the PSA density, they suggest that we can consider a biopsy. If both the PSA matrix is low and the pyrite score is low, you can safely observe these patients and not do biopsies. This is a very useful tool, I think, or most of the residents should know about it, so that they can actually make a decision on whether to wait on patients or go ahead with a biopsy. I'll skip these. So like Dr. Raghunath has already mentioned, the transperineal biopsy is probably the best possible way to do biopsy in the current era. That's what even the EAU recommends, and it's probably better when the suspected lesions are anterior. And the EAU recommends that we should draw multiple cores even from the lesions, so that we generally end up not missing the diagnosis. Now, Dr. Raghunath sir, again, can we avoid a biopsy just based on the MRI alone?
Yeah, if the pyrites lesion is say 1 or 2, probably I would convince the patient of clinically normal PSA, low PSA, and if there is no clinical index of suspicion and MRI is showing 1 and 2 pyrites, probably I would convince the patient to not to go for biopsy at that point of time, but I would certainly observe with PSA, because even the MP-MRI is not 100% accurate. Its sensitivity and specificity and even negative predictive value is probably around 80 to 85%. So it can miss. So just with MP-MRI findings, I would not go. I would always convince the patient to follow up. If it is
the key point here to drive in is that the patient has to actually be on a strict follow-up. I think that's the key. One evaluation or 2 evaluations may not suffice. The patient must be, very diligent with his follow-up. So this is, sorry.
May I just quickly cut in? This is an open question to the senior panel members here, Dr. Raghunath, Dr. Yuvraj, Dr. Kishore, and Dr. Santosh. What are your thoughts about the new papers that have come out where they're doing radical prostatectomy without biopsy, where there's a corroboration between MP-MRI and PSMA PET? So I want 4 of them to quickly give your answers, please.
I would not do at this point of time without biopsy in my clinical practice.
Dr. Yuvraj?
Same thing, Anand. I don't think yet we have reached that level that we can do a prostatectomy without doing a biopsy. I don't think we should do that. So in future, I think there are many things are coming up. I think in future there is a hope, but not now.
Dr. Santosh?
Yeah, a very small group of retrospective, very selective patients, and with the garb of the fact that they were very scared of biopsy and would not take biopsy, this thing has been done and published. So I think it should be, as a rule, as of now, we should not take it. In future, we'll know if there is more evidence and 100% NPV negative predictive value or positive predictive value, then it is a different thing altogether. It's a thing, but as of now, it requires a lot of push in the right direction before we take it as anything close to normal practice.
Dr. Kishore? Okay, so we'll go ahead, Dr. Srivan.
So we come back to our case, Harsha. So we did an MP-MRI on this patient. He had a 33 cc prostate with intact peripheral zone on both sides. There was one pyrite stool lesion in the transition zone in the left lobe of the prostate, subcentimetric actually. I have not put in the measurements. Would you really want to biopsy him at this stage?
Not at this point of time, sir. Not at this point of time. I'd really like to follow him up. Maybe put him in sort of semi-active surveillance sort of protocol. So follow him up with both PSA metrics as well as with MP-MRI as need arise depending on the PSA metrics. See, my rationale for that will be to start with, this is a very low risk disease. Maybe we can say it's a very low risk disease, not even low risk. So in that scenario, we can still wait and follow him up, and subsequently, anything shows up on the radar, we can always proceed to the biopsy, but not this lesion. No.
I would like to add something on this. I think we should counsel the patient he has a PSA of 5.6. I agree with Harsha that he may not be a candidate for very suspicious significant cancers, and but we should counsel him that there is still a chance of probably a less than 10% chance of having a cancer. Also, we should look at like you showed in that other picture of PSA density. PSA density we can factor in, and risk stratified approach we can probably see in this case. If it is more than 0.2, then even in PARADS 2, you can counsel the patient for that. But yes, very cautiously, you have to take this patient for biopsy.
So this is exactly what we told him, that we would really want to observe him for the moment. But here he was from America. He had just come to visit his father for a couple of months. He was in a hurry to go back, so he requested for a biopsy, considering that his father was already diagnosed with prostate cancer. He said, I really don't want to remain uncertain. I want to get the biopsy done here and see how to take it forward. So we did go ahead and biopsy him. Unfortunately, we don't have a facility for transperineal biopsy. We did a truss-guided 12-core biopsy. This was the pathology, histopathology report. 3+3 adenocarcinoma of the prostate, no lymphovascular invasion or perineural invasion. 3 cores were positive, but with 1 core showing more than 50% core length involvement. So this is where we are. He had CA prostate, like expected, low-risk disease, but 1 core is showing more than 50% core length involvement. I think Dr. Puneet has already answered this. Have we done enough on this patient already? We have done an MPMRI, 3+3 disease. Would you want to stage him at all any further, or would you want to make your decision on treatment based on this? Dr. Puneet?
Yeah, so like I said earlier, there's no strict indication for doing a PSMA PET in this case. And you can actually cross-sectional imaging or MRI would be enough for this is a low-risk patient. But in actual practice, usually everyone does a PSMA PET because patients sometimes also are very anxious. So that is the reason for doing it. But otherwise, if you go by indications, there's no indication for doing a PSMA PET in this case.
Exactly. So on request, we also did a PSMA PET CT, which was more or less corroborative of what the MRI showed. There was intense uptake in the left lobe of the prostate with a very high SU value. So now coming back to the treatment. Now, Dr. Puneet, will start with you. Would you like to observe this patient, or would you want to treat him?
So again, low-risk patients with the good life expectancy, we can counsel him about all the 3 options. So even in your this recently data about PROTECT trial, also for 15 years, you have seen that for these low-risk patients, you can offer them active surveillance, you can offer them RP and offer them radiation as well. So the overall prostate cancer survival rates are not different, but yes, it has been seen that if in active monitoring, usually the metastatic rates over 15 years are a little higher as compared to a definitive treatment of prostatectomy and radiotherapy. So after counseling all this, and if the patient is motivated, we can offer him active surveillance. Otherwise, I'll go for a definitive treatment.
Yeah, Raghunath sir, now that we know that his father had prostate cancer, he's had prostate cancer. He's 61 though. Do you think that there is some role for HR mutational testing, at least some germline testing on this patient?
Definitely, it is required based on his father's disease status. His father had, metastatic prostate cancer, and he also has. Definitely, I would like to do genetic evaluation. And when it comes to observation versus treatment, probably
I would like to stop you here just to ask you a quick question.
Certainly, I would do germline mutation. Yes.
Yeah. So if you want to do a germline testing, do you think that the outcome of the test will impact the way you are going to choose the treatment on this patient?
Definitely, yes. Yes.
Would you? I mean, for example, if he is BRCA2 positive, would you want to still observe him, or would you go ahead with treatment?
Can I ask you a question, Dr. Srivastava?
Yes.
So at what age his father was diagnosed with a metastatic prostate cancer? Because if you're doing a genetic evaluation for a patient with a family history and only this factor and no other cancers and no other relatives, and then that I think the age of the patient of a family member should be less than 60 years or something. If the father is diagnosed at 80 years with a cancer, and you cannot actually consider it as a family history. Others can comment on this. I think
one more point I would like to highlight here. The SUV value in PSMA PET scan is very high, 18. There are some papers. If the SUV value is higher, chances of having high-grade tumors are very high. So based on that, probably I would not put him on active surveillance. I would counsel him for active treatment, and definitely I would advise him to go for genetic evaluation.
So, do you think that we can tell him about the PROTECT data, or tell him about the outcomes from the radiation treatment as well, or do you think that it is good practice to refer them and let them have a chat with the radiation oncologist as well? Open to all.
Ideally, they should take, when we are suggesting active treatment, MDT is required, and better to, involve radiation oncologists in the treatment planning.
May I quickly cut in and ask the rest of the panel, Dr. Yuvraj, Dr. Santosh, and Dr. Raghu. Now, if the germline testing is negative, would your indication for active treatment change? Or just take away the SUV value for a minute, but this patient with the low-grade prostate cancer, how would you go about it, given the data that you got in the PROTECT trial just recently?
See, in the PROTECT trial, most of the Caucasians, 30% of them do not require any treatment. They fall into very low risk and low risk prostate cancers. In India, you have seen in India, even 3+3 post-surgery, upstaging or upgrading is very common. So hardly we see 3+3 in India. Very few. Probably if he is one amongst them, probably I would active surveillance would benefit him. Otherwise, in clinical practice, probably it's very difficult. But we have to discuss all these points with this patient before planning any treatment.
So Raghu sir says Indians don't do well with active surveillance. What about Dr. Yuvraj and Dr. Santosh?
If I say this patient has two factors, one is family history of metastatic disease. Second, the fact that he's visiting from USA to a center where he feels that his treatment will be at 1/10 the cost with the same expertise, and he would get treated and go back home. So with these two factors in, it is very difficult to convince this patient to be on active surveillance. It's just not possible for a person in US to be on active surveillance in India. There's no way. He's going to go back to US, somebody there is going to do something, and he'll not be able to get back to you or this thing. So with these two factors, I have found this type of patient. We do get a lot of relatives and people from Kerala whose people are, it is extremely difficult to convince somebody who has a family history of death or metastatic disease from a disease which he has been found early. It just plays in their brain so badly that it will be very difficult to keep such patients on active surveillance. The fact is, at present, he can be kept on active surveillance. That is a different thing. Whether treatment will make a difference to his life is a different thing. But to keep this patient practically on active surveillance will be impossible.
Okay,
he was very categorical that he wanted to continue to be sexually active. So at some point, there is always that risk that with some treatment, whatever it is, whatever nerve sparing or very targeted radiotherapy we do, there is an element of risk that the sexual activity could be compromised. So we really like everybody has highlighted. I think it should be a very carefully dealt decision. All pros and cons of all treatment should be exhaustively discussed, especially with the availability of PROTECT data, which shows that the overall survival, prostate cancer survival with active monitoring did not fare worse at all. If you look at the 15-year data, it's almost more or less the same compared to both the prostatectomy and the radiotherapy groups. Yes, Dr. Anand mentioned that the number of metastatic events were more, but the survival did not alter. So, so if you really, carefully have to look at these kind of patients, I think it's only fair that everything is discussed in great detail. Now, assuming that, we are all surgeons sitting here, so assuming that, we have offered surgery, all that, and the patient has accepted to go ahead with the surgery, I want to ask Harsha, would you want to do a lymph node dissection on him? And if you do, what would be the template?
So, as per the data, lymph node dissection is not going to yield much of extra information, sir. The chance of take-up and metastasis is pretty low in this particular patient. So, having said that, doing a small staging lymph node on both the sides should be enough for this patient, and I will do that staging lymph node.
Staging where? Would you like to do the internal iliac?
I'd like to do the internal iliac and obturator pocket and leaving the external iliac and the common iliac away. Just the internal iliac and obturator will do.
Yeah. And would you want to, offer him an open surgery lab or robotic? I mean, what is this decision of access of surgery based on?
So I'd like to offer him robotic only, sir. The primary reason being I am more trained in robotic than other modalities of surgery. So that is one. And in these days, I think we can do a much better job on robotic versus the other modalities of surgery, because his primary target being sexual preservation. I think we'll do a much better job at nerve preservation in robotic surgery versus other.
Yeah, I think it's a fair point, Dr. Harsha, that keeping nerve preservation in mind, I think minimal access surgery definitely will be better than open surgery. And lab, I think, is now becoming very, very niche. Very few people do good lab work. So I think with the more availability of robot, I think it's only fair that we offer it robotic over the other modalities of surgery. Raghunath sir, what would be your choice of surgical technique? There's so many ways to do prostatectomy. It's really confusing. You have done transperineal now. Rawal sir is doing transcoccygeal. What do you think it should be the ideal mode of technique?
I mean, it depends on one's experience. My experience with Retzius-sparing is very limited. Even for that matter, transperineal is also very limited. I would probably go with the hood technique of nerve preservation. I think I would resort to hood technique only. I would not venture into any other techniques.
Yeah, Dr. Puneet, your comment before I ask Dr. Kishore.
Yeah, so I think for this case particularly, all the techniques are possible. Retzius-sparing is possible and conventional is possible. So whatever the surgeon is most experienced with should go ahead with that technique.
Dr. Kishore, I'm sure you will always vouch for the Retzius-sparing. Do you think that it is a distinct advantage over the other techniques, or how do you position it? Dr. Kishore? I think, okay. Do we have Gagan, or Gagan is not yet joined?
We'll go to the pathology, please. Go ahead. Last slide.
Yeah.
I think we're running out of
I think
time.
we're done with the first case. Do we have time for the second case?
A quick few points, and then we should wind up.
2 minutes.
So quickly, this is a 62-year-old smoker with good performance status. He's hypertensive, on medication, sexually not active, had obstructive LUTs for about 6 months duration, was started on an alpha blocker, didn't respond very well, and subsequently got a second opinion where somebody did a digital rectal examination, found to have a nodular grade 2 prostatomegaly. His PSA was 12. And then he was sent to us for further evaluation and management. We did an MPMRI 40 cc gland with multiple pyrex 4 nodules in both peripheral zones of the prostate with doubtful involvement of bases of both seminal vesicles. With this background, we went ahead and did a truss biopsy. The pathology returned back as Gleason 4+3 adenocarcinoma of the prostate with lymphovascular invasion positive. Many cores were positive. And then we did a PSMA PET CT scan, which showed an increased uptake in the entire prostate. The seminal vesicles also show uptake on the PSMA PET CT scan, and the nuclear physician reported that the planes with rectum was not well defined. Dr. Harsha, I want to quickly ask you, when would you want to do a PET CT scan after the biopsy? And will you be worried that the PET CT scan report says that the planes with the rectum are not well defined? What are your thoughts?
So to start with, I don't think PET CT scan is a very sensitive investigation to define planes between rectum and prostate. So I think if it is coming out of an MRI, it's a different interpretation, whereas PET-CT scan, not so sensitive. Even the periglandular inflammation or other factors can be considered as infiltration on a CT scan, which can be better seen on an MRI. So I don't think we should take it on its face value saying that that is
absolutely, especially now that we are doing an MRI prior to the biopsy. I think we should rely heavily on the biopsy MRI for the local staging rather than the PET. Now, when would you want to really do a PET? The biopsy comes, everybody is anxious, they want to know the stage. What stage am I in? So when would you really feel that is ideal to do a PSMA PET-CT scan?
In the sense, the timing of the PET scan?
Yeah, timing of the PET-CT scan. After how many days after biopsy?
I really don't think it makes any difference, sir. If you do the PET scan immediately after the biopsy or before the biopsy or after the biopsy, here the PET scan is mainly intended for staging purpose. It's not for the local staging purpose, because the local staging is already done by the MRI, and the PSMA PET is mainly done for the distant staging purpose. So you can offer it if they are willing to do it right away, immediately after the biopsy also, or at the time just before the surgery.
Dr. Raghunath,
I really don't think it makes any difference.
Okay. Dr. Raghunath, your take on this, sir?
I don't do PSMA PET scan soon after biopsy. We have seen a couple of false positive lymph nodes with a low PSMA avidity. It's very difficult to decide whether you need extended lymphadenectomy or limited lymphadenectomy, all those things. So I generally wait for minimum 10 days.
Okay, so you feel that it's better to wait for about 10 days after the biopsy to do a PET-CT scan.
Yes, minimum. Yes.
That is to prevent potential upstaging of the disease, false upstaging of the disease.
Yes.
Okay. Dr. Puneet, this question to you. What are his treatment choices? He has a Gleason 4+3. MRI says that there is a potential seminal vesicle involvement. The guideline is clear. This is a high risk. Probably I can't call it organ confined because there is a doubtful seminal vesicle involvement. We might accept it as a high risk organ confined for all practical purposes.
Most likely a high risk organ confined. So treatment choices definitely would be one of the two, ADT plus radiation versus radical prostatectomy. Now, if the patient has a free rectal plane by DRE and by MRI, and also the patient has a significant obstructive LUTS, you can offer him a surgery. Otherwise, for high risk, if you think it is an advanced disease, ADT plus radiation. So these are the two options for him.
Yeah, Dr. Raghunath, what are your choices? What would you choose on this patient?
And I would not give him any neoadjuvant hormone therapy.
Since he has obstructive LUTS, and recent meta-analysis says that by including radical prostatectomy as a part of multimodality therapy, the survival advantage at 10 years is more than 15%, as against hormone therapy and radiotherapy. Probably I would go with surgery. But surgery as a part of multimodality therapy, because it's a high volume disease and possible seminal vesicle infiltration, and he has lower urinary tract symptoms. Based on all these things, probably I would convince him for multimodality therapy, starting with radical prostatectomy, and keep an option of radiotherapy for future.
Yeah. Would you want to use neoadjuvant hormone therapy before you plan your surgery?
We have experience of more than 100. We are just collecting the data. In my clinical practice, we are using. We are really happy with that. Our surgical margin positivities have come down significantly, and post neoadjuvant, if the disease regression is very good, if it is less than 0.5 centimeters, probably we don't see biochemical recurrence in such cases. So, but it's very difficult to say at this point of time.
I think
so if at all you want to use a neoadjuvant hormone therapy, forgetting the evidence available today, what would those points be?
There is some evidence. There is some evidence. There are a couple of papers are there where they use intense neoadjuvant hormone therapy, where they give Degarlix plus 6 months of either abiraterone or enzalutamide. Even apalutamide and darolutamide studies are there. And some papers are from James system, even chemotherapy results are available. With 10 years, overall survival is better with a hazard ratio of 0.68 with a neoadjuvant chemotherapy. So this some evidence is there, but you need to wait for long-term results, and level 1 evidence is not there.
Okay, Dr. Puneet, if there is some index patient where you would want to use neoadjuvant hormone therapy, who would that be? or it's a categorical no?
So a patient wants a surgery because of, and plus there are obstructive fluids, large gland, probably a locally advanced disease. In that case, you can consider. Otherwise, from my side, I don't give it.
So locally advanced disease, a doubtful rectal serosal fixity, where you want kind of downsize, and put
You'll
this
have to
patient.
again image that patient probably after a couple of months and then see.
Correct. So that's what even the EAU recommends, that radical prostatectomy in a relatively young patient with at least a 10-year life expectancy should be offered radical prostatectomy as a part of multimodality therapy. The recommendation strength is strong, so it's not incorrect to offer these patients radical prostatectomy. Harsha, you said you want to just clear the iliac and the internal iliac and obturator in the first case. Here, what would be your extent of lymphadenectomy?
So here, extended lymphadenectomy will benefit the patient, sir. I think we should and clear that area. So extended lymph node to be specific has always shown. I mean, even the EAU guidelines says that if you do a lymphadenectomy in such a high risk case, you do an EPLND, which confers a benefit. Otherwise, there is no point of doing any other lymph node dissection.
Yeah, so that's the guideline highlighted again. Perform an extended pelvic lymph node dissection in high-risk prostate cancer. And what would be your template? Would you be doing the clearance of fossa of Marseille, or would you be just preserving, restricting yourself to, the internal iliac, the external iliac, and the obturator nodes?
No, sir, not just internal iliac, external iliac. I think we should go up to the level of common iliac and the area.
Hello, Srivat.
Exactly.
Let's go to your last slide, please. I think we're out of time right now.
Yeah, so so I just conclude in the last two slides. He underwent upfront radical prostatectomy with extended pelvic lymphadenectomy. This is the pathology report. He got upgraded from 4+3 to 4+4. Both seminal vesicles were involved. Two margins were focally positive. In the base of the prostate on the left side, all lymph nodes were negative. If Dr. Anila is still there, Madam, can you tell us what is this focal positivity actually mean? Dr. Anila, is she there?
Yeah, I can hear you. Two
Yes,
margins focally positive. I really don't know. Normally, we give the length of the involvement in millimeters. And if it is extra prostatic extension and it is away from the margin, we say how many millimeters it is away from this. This I really am not very familiar with what focal positivity is. We normally quantify it.
So,
Yeah,
so
that's
the point here, the point here I want, sorry, sir, please go ahead.
No, Srivatsan, you go ahead, please.
Yeah, the point here I wanted to highlight is the margin could still be positive. The disease can be extra prostatic, but the margin may not be positive. So these are two different things that, the patient can have an extra prostatic extension, like in this case where the seminal vesicles were involved, but the margins there were negative. And we should be really looking at the margins rather than the extra prostatic extension. And like ma'am said, I think describing the extent of margin positivity in length is very important. And not only that, I think the pathologist should also opine on the Gleason at the positive margin, whether it's a Gleason 3 or a Gleason 4 or a Gleason, whatever is the Gleason in the positive margin should also be highlighted, so that subsequent adjuvant or salvage therapeutic decision can be made. So Raghunath sir, do you feel that there is any role of adjuvant therapy in this patient? These are my last few slides.
No, I would not consider adjuvant therapy in this particular case, though seminal vesicle and even focal margin positivity is there, 4+4 is there. I would definitely wait with PSA. In case if PSA rise is there, probably I would go for early salvage rather than adjuvant.
Dr. Puneet, your take on it? Would you want to do adjuvant therapy on this patient?
Oh, I agree with Raghunath sir. I would also wait for PSA, and if PSA is rising, then early salvage. But in literature, they've said that in EAU guidelines, especially that if it's a margin positive disease, and in this case, like pathological node negative disease, you should offer radiation to these patients, adjuvant radiation to these patients. But I would, in my practice, I do early salvage.
So this is something that's very interesting that I have come across in 2023 EAU because this was not there in the previous editions of EAU. They say that you should you need not offer adjuvant ADT if the patients are node negative, but if they have a Gleason grade group of 4 or 5 or PT3, that's either A or B, plus or minus positive margins, they recommend that we should offer them adjuvant radiation. And not only that, what they say is there is no threshold like the gospel number of 0.2 that we have been very conscientiously following, that up until the PSA becomes 0.2, the patient is biochemically free from disease. The moment it is 0.2 and above, it is biochemical recurrence. The current EAU recommendation is that there is no such threshold. If there are 2 consecutive rises in PSA, regardless of the PSA value, I think we should consider, that's what they say, do not wait for a PSA threshold before starting treatment. Once the decision of salvage radiation has been made, it should be given as soon as possible. I think these are the 2 new changes that the EAU 2023 has come up with. So most of us practice that early salvage radiotherapy based on the radicals and the RAGE data, but I think this is the EAU guideline, so it's up for debate. I think I'll conclude with this. Thank you very much, all the panelists and the senior faculty to have chipped in. Thank you, Anand sir.
I think that Dr. Santosh has a quick point to make.
Yes, sir.
Yeah, I have a big series of patients with bladder outflow obstruction, T3B disease, and so these patients we have successfully treated with URP at that time, neoadjuvant hormonal therapy and radiation, and very good follow-up, good continence rates, and no problem. That treatment option hasn't been discussed. I think that is an option for these patients. Do the TURP at the same time do hormonal therapy. 3 months later, you can give radiation. And the thing that we say that multimodal therapy, a lot of patients are put off when you say that you do surgery and give radiation. And they are very happy if you say that they have radiation as their primary treatment and they are rid of the bladder outflow obstruction immediately with the TURP. Much less to be lost than with surgery.
Thank you, Dr. Santosh.
That's one point I wanted to make. Thank you.
Thank you very much. I think before we go, I must hand it over to Dr. Ravi, but I must thank Dr. Amit Ghosh for his vision for the uro-oncology subsection. He's always had education as its forefront vision. Thank you, sir. Over to Dr. Ravi.
Thank you, Dr. Anand, for a wonderful webinar. I think we brought a lot of new discussions and points. Thank you, the experts and the panelists and both the speakers. I think they did a wonderful job, especially Anila Madam. You cleared a lot of thoughts on pathology. So, as a secretary, I would request you, and Dr. Amit Ghosh already mentioned in his initial introductory remark, that we must register. Let's try to register both for the uro-oncology subsection as well as for this meeting, because without that we cannot make this meeting successful. So as you all know, our registration the early bird registration is till 10th May. So I sincerely request that everyone should register it because it's mandatory. And in continuation with this webinar series, we would do the 4th webinar on 10th of April 2023. This would be on hormone-sensitive prostate cancer, and this will be done by Professor Narmada Gupta sir, and everyone knows him. He is our Bhishma Pitamaha. So see you on 10th of April. Thank you very much. And may I request the council members of USA subsection to stay logged in. We will have a small discussion after this. Thank you.
Thank you so much.